I was diagnosed when I was 9 years old. So I've been diabetic for about 23 years now. And it's kind of the whole reason that I got into optometry, got interested at a young age, going to my annual eye exams and befriending my local optometrist. I got intrigued every time I went in about how your overall health can affect your vision and how you see. So I grew up in Wisconsin and I went to UW-Madison for my undergrad, and then I went out to Philadelphia for my optometry school, which is a 4-year degree where you study to become a doctorate of optometry, which is different than ophthalmology, where you actually go to medical school first and then you specialize in eyes and train to do eye surgeries for the most part. So your cataract surgery, your LASIK procedures, things like that, the ophthalmologists are doing. And I also did a little bit of specialty work in my residency in pediatrics and vision therapy and rehabilitation, took on a little bit more of an interest in the functional vision. And currently I moved back to Minneapolis area about 4 years ago. I work at McDonald Eye Care Associates just south of the city in Lakeville. So I've been there ever since, doing primary care such as like diabetic eye exams, managing disease, doing evals with testing, emergency care, and then vision therapy. So the annual diabetic eye exam, I wanted to kind of go over different areas of the eye that we pay attention to and why it's important to have your annual eye exam. We'll go through some different kind of conditions and then just some general eye health as well. The most important part of your diabetic eye exam is the dilation, where your pupil gets nice and big and we can see into the back inside layers of your eyes. But kind of just going over a little bit of the anatomy here so we can get into some of the other areas that we look at. Like the cornea is the clear front surface of the eye. The natural lens in your eye, as people are mentioning, is where you get cataract surgery. And in the retina is where all your blood vessels are that we pay special attention to as diabetics. And your optic nerve connects the eyes to the brain. You actually see with your brain, which I always find interesting as well. So the different layers of the eyes can have different types of complications or changes from diabetes. The retina, like I mentioned, those back layers of the eyes where you can get the diabetic retinopathy, which is usually what your primary care or your endocrinologist asks you about when you come to your visits with them. We can be more at risk for things like cataracts and different types of cataracts in the natural lens in the eye. The optic nerve is where you can get glaucoma, and that's why we always do a pre-screener of your eye pressure when you come in for your visits. You can get different changes to your veins and arteries where they get occluded. So those
is that the puff of smoke that they blow into your eyes for the pressure?
Yes, yeah, the puff of air one, which most clinics has as a screener, or there's another one that kind of looks like a little probe that we have at our office now. We haven't had the puff of air for a couple of years now, which patients appreciate, that they don't have to endure that one. It's a little bit more of a startle than some of the newer versions of it, but they all work, very similar, just kind of different methods to be able to measure eye pressure. And I think a commonly overlooked area is the front surface of the eye, the cornea, where you can get dry eye. And being diabetics are a little more at risk for that as well. So different risk factors that can impact your chances of having ocular complications is just our overall A1C control. And sometimes even though our A1C is within the range that our provider might like, we also don't want to have a lot of peaks and valleys. So our time and range along with the A1C are very important. The longer that we are diabetic, even if we have good control, we still can get eye complications. And then other conditions that can put us at risk for changes in the eye. We also have troubles with our blood pressure, cholesterol, iron levels, kidneys, things like that can all impact if we have kind of dual disease mechanisms going on. So diabetic retinopathy, like I said, is one of our major concerns because it's one of the major reasons that adults in the age range of 20 to 74 can have blindness in the United States. A lot of times patients will come in and complain just about things like blurred vision or a spot in their vision, kind of hazy vision. And so looking at all the different parts of the eyes, we can kind of see what's going on. But there's also different levels of diabetic retinopathy. I did a couple pictures here at the bottom, as you can see, but types of changes you can get with retinopathy are little microaneurysms, a specific type of blood hemorrhage where it looks like a little blotch or a little dot. We can get fluid buildup in the back of our eye, edema. Exudates, where it's kind of the discharge of the garbage in our blood vessels expelling into the retinal area. And we get new blood vessel growth, new vascularization, which is not as efficient as our regular blood vessels and can cause complications. So with diabetic retinopathy, like I said, the longer that we've just been diabetic, even with good control, can increase our chances. So if we've been diabetic for greater than 10 years, there's a chance that there's some sort of diabetic retinopathy that we've had. And greater than 20 years for type 1 diabetics, there's a 95% chance that we've had some sort of diabetic retinopathy throughout the years, whether active or inactive. So the treatment for diabetic retinopathy is our overall diabetic control, but sometimes we have to go in the retinal surgeons with different types of lasers to help stop the excessive blood leakage from the blood vessels, or use injections to help with the fluid in the back of our eye. So things that can help reduce the amount of diabetic retinopathy that we have is if we reduce our A1C by about 10%, there's a 45 to 50% improvement in diabetic retinopathy. So say our A1C is at a 10, if we even lower it to a 9, there can be significant improvements in the health of our eyes.
With those pictures, can you go over the difference between normal and mild? I wasn't able to see too much. I could see a lot more bright spots with the moderate and proliferative.
You bet. So normal eye here, this is our optic nerve. Can you see my mouse over it?
Yep.
Okay, so this is our optic nerve here. And then our veins and arteries here in our central vision, our macular area, that's where we get like our 20/20 vision. And so we look at the appearance of the optic nerve, making sure that it's nice distinct borders. We watch the blood vessel patterns, and all of these look normal in this image. We move on to like a mild form. You see kind of a couple of red spots. Yeah, sorry, this picture isn't super big. But a couple of red spots outside of those blood vessel passages here. And that would just be a very mild form. So usually like one quadrant can have a couple little dot blot hemorrhages, which we can tell a difference from say someone who just has hypertensive retinopathy and they look more like a kind of like a flame shaped hemorrhage. And so even when we see hemorrhages in the back of the eye, we can usually tell what sort of disease process it might be from. And then moderate, you're seeing kind of some of these brighter spots here. Those are those exudatives, kind of the garbage disposal of the coming out of the leaky blood vessels. And that severity, like going down the line here, is severe, is that it's involved in all 4 quadrants. So it kind of depends on how many areas of the back of the eye are involved in the severity level as well. And then proliferative is more when you have new blood vessel growth, like new vascularization and macular edema, that then usually the surgeons need to treat. And sometimes you'll have a group of hemorrhages too that you might get like laser treatment from, but not usually until it's more in the severe to proliferative category, depending on the location. So the closer it is to your central vision, the more concerning it is for things like blindness. And so the surgeons might be a little bit more proactive in treating it than just watching your overall health. And I did a little bit bigger picture here. It's a kind of blurry, but I wanted to kind of show the normal eye here with all the blood vessels having nice kind of bends and curves to them, the way they cross over one another, they're not compressing one another, causing like lack of blood flow or hemorrhaging. But then over here, it's kind of, this would be a severe eye or a proliferative eye where you're having basically all the types of possible retinopathy changes in this image here. So cataracts are another eye complication that we can get as diabetics. We're 2 to 5 times more likely to have cataracts and a specific type of cataract. The cataract-like picture over here with the snowflake is the type that we're a little bit more prone to, or just cataracts at an earlier age. So say the average age is like 71 for cataract surgery for the average person. So we are more likely to say get them in our maybe 50s or 60s versus a non-diabetic. But like some people were mentioning, cataracts can kind of be a blessing in disguise if we do have glasses or contacts, because when we measure your prescription, there's 2 areas that we take into your prescription, the cornea and the lens. And the cataracts form in the natural lens in the eye here. And so what we can do, the surgeons can go in, make a little incision in the cornea, they can take out, kind of crumple up the cataract, take it out, and then they implant a new clear lens. And when they implant that lens, they can actually implant prescription. So say you're nearsighted, you have like a -6 prescription, you've been always wearing glasses since you're a young kid for the distance vision. Once you get cataract surgery, they can implant that -6 right in this lens. And then you might just need glasses, say for reading, but your distance vision looks really good. So cataracts can be scary because it causes that very hazy vision, halos and starbursts around lights when you're driving, needing a lot more light to do things like read. But once you get cataract surgery, it can be very beneficial to your overall clarity of vision, having whiter, brighter vision, but also not being as dependent on glasses and contacts. So glaucoma is a disease process that can affect the optic nerve, which connects the eyes to the brain, where you have increased eye pressure and it causes damage to the optic nerve, and it can cause side or peripheral vision loss. So the eye pressure is the screener for it. If the little puff of air or the little probe comes back as high, the doctor usually rechecks it with another more accurate eye pressure instrument in the exam lane. But the treatment for it can be just to use an eye drop, which can be help to lower the eye pressure, which can take pressure off the optic and prevent that side or peripheral vision loss. It's also just increased the longer that we're around. And so age and family history can play into our probability of getting glaucoma. So if you come in every year for your eye exam, we can screen for the eye pressure. And if it's getting higher and higher over the years, we'll do additional testing, like a visual field where you look in with one eye at a time at a spot in your central vision. And when you see flickers of light off to the side, you click a button, and that tells us very detailed areas of your visual field that you may be having a hard time with, and those correlate to very specific areas of your optic nerve or your nerve fiber layers. So most people wouldn't notice that they had peripheral vision loss until you lose a lot and you have tunnel vision. So we always want to catch that before it gets that bad. There's different types of glaucoma, and we're a little bit more at risk for the neovascular type with the new blood vessel growth, when we're having troubles with our own blood vessels with the veins and arteries in the back of our eye. So sometimes we actually do get symptoms like pain and redness with the neovascular glaucoma, but a lot of times it's a symptomless disease process until it's really severe. And so it's a really important one to have the screener for. So the different ways we look at the retina with the dilation, we look in with different like lights and lenses. But we also can do these images, which most offices call like a retinal scan or an optos image. And you can see different retinal disease processes here where you have a lot of blood hemorrhages or blood outside the blood vessels, or you're not having adequate blood flow. So vein and artery occlusions are two types of retinal diseases that we can be more at risk for, where they impact all the blood vessels like they are here, or just a quadrant of the blood vessels, which you can have very sudden changes to your vision with these ones. And you want to go in right away if you're having like a blacking out of your vision, or you're suddenly missing a whole area of your vision. And we like to get that treated right away to have the most success for regaining vision. So dry eye disease, as diabetics, we can be more at risk for ocular surface inflammation. But a lot of people come and complain about every time they're blinking, their vision is changing, and they think it's like their contacts or their glasses. But really, if our ocular surface, those clear layers of the cornea, aren't having consistent coverage with our tears, it's like looking through a dirty windshield. You're not going to have clear vision because your tear coverage is not adequate all the way across your eye. And you're gonna have lots of fluctuations to your vision every time you're blinking and re-wetting your eye. Other people will complain about the redness of their eyes, or almost like something's in their eye because of the dry spots on the front surface. It'll almost feel like there's something in their eye, like sand, or like an eyelash in their eye. Lots of different ways that we can manage or treat dry eye disease though. Most of the time we start with different things like lubrication drops or artificial tears, where we supplement and have more tears on our eyes. But there's also medications that can help us to produce more tears and help calm the surface inflammation so that our eyes feel more comfortable. There's also glands in our eyes here, as you can kind of see in the picture. So every time we blink, these glands secrete a little bit of oil, and that oil helps to coat our outer tear film layer. And so if we're not getting good meibomian gland or oil gland functionality, then our tears can evaporate more quickly, and it can cause those dry patches and changes to our vision. And so you can use different things like hot compress on the eyelids. We have some procedures in office that we can do to help with the glands from the inside and the outside, and can clear obstructions if they get kind of clogged. Can be more susceptible for things like styes. And so all these different areas of the tear film can be impacted by different processes for the dry eye.
Hey, Kelsey, I was wondering, it sounds like there's a lot of benefits to cataracts, and then you get to kind of fix your vision and get a whole new lens. Do those people that generally get that surgery, do they get dry eyes afterwards, or other surgeries that cause maybe dry eyes?
So if you especially start out with a dry eye, it can exacerbate that dryness. But the number one side effect of LASIK and a lot of times of cataract surgery is dry eye disease, because it disrupts that kind of homeostasis of our eyes. And so we always want to get things started and get things treated before you were to go in for a procedure like that.
Okay.
But mostly, or especially the refractive procedures like LASIK or PRK, a lot of people have dryness for the first year after surgery, and then it can get better. Females are a little bit more likely to have dry eye disease as well, so we're lucky in that matter, especially after menopause. And so there's about an 80% chance that a woman over the age of 40 to 45 will start to have some sort of dry eye symptoms.
What is PRK?
Oh, so there's different types of surgeries that you can do to the cornea to help correct for nearsightedness. And so LASIK, you do a flap on the cornea of the outermost layer of the cornea. You open the flap, they treat it with laser to reshape the cornea, and then they put the flap back down. And then it heals pretty quickly. That one you can heal from in like a day, that your vision is pretty consistent and improves over time. But PRK, they don't do the flap, they just resurface the front of the cornea. And then you put a bandaged contact lens on for about a week until that top epithelial layer of your cornea starts to regrow. And so it can be a longer healing process, but a different way to correct someone who's nearsighted but also has astigmatism. A lot of times they'll have to do the PRK version. And so just a different way to be less glasses dependent with the refractive procedures.
Teresa, did that make sense, or did that sound like Greek?
No, that makes sense.
Okay.
I didn't, all these abbreviations and I don't know what they mean.
Oh, yes. Sorry about that. Let me know if there's anything that I can elaborate on.
Yeah, no,
Thank
that's
you.
good. I wasn't sure with certain people. Nearsightedness means you can see near, not far. Farsightedness means you can see far, not necessarily near, and so you need reading glasses. Just to kind of recap, I guess, a couple things. But
Yeah.
if there's other questions too, I mean, I feel like that there's a lot of words too where I'm like, oh.
Yeah. Just stop me and let me know.
So feel free to ask questions, guys, making sure you're taking them home.
Kelsey, I have a question. So I just had that cataract surgery and I've never had high pressure before in my eyes, and now I have it.
Yes.
And the doctor says it might be from the steroid drops, which is that gonna go away, or and it seems like every time I've had to go back in there like 3-4 times since, and it's only been 2 weeks, but I've had other things that have cropped up too besides the high pressure.
Yeah, so when we have cataract surgery and you have to be on steroids to help with inflammation after surgery, the eye pressure can go up if you're a steroid responder. So if you've never been on a topical or a eye drop for steroids before, it's hard to predict that reaction if you're going to be a steroid responder or not and have the increased eye pressure. Typically, it's only when you're on the eye drop, though, post-surgery, it'll go down as soon as you stop that eye drop. Sometimes, depending on the level of your eye pressure, a little bit is okay, to be a little bit outside the normals for those couple weeks after surgery. But if it gets above a certain number, then we usually start to add in a glaucoma drop that helps to lower your eye pressure, just to kind of counterbalance while you're on the steroid.
So that's what they did do, but I'm still kind of high. I went into day 2 and it was still at a level of 30.
Okay.
So, but he cut me back on the steroid drop down to 1, but it's a little concerning that, it's scary, especially, because I had the other edema problems too, which mine's right in the center, so they can't do any laser on me, so.
Yeah, and so when you have kind of like a pre-existing, like the macular edema or fluid in the back of your eye, and then you have cataract surgery, there's a chance that it can flare it up. And so being on the topical or the eye drops for steroids and the non-steroidal anti-inflammatory drops are going to be really, really necessary and usually extended for people who have that as a pre-existing condition. And so it's good that he or she could lower the amount of steroid that you're taking, but I assume that you would be on it for a little bit longer than a month, just based on already having some of those macular changes or those central vision fluid changes.
He has me on another eye drop too, cataract or Cataracts. Yeah.
Yeah.
So he wanted me to take more of that, and then also now I can't remember what I was going to say, but anyways, thank you for answering.
Yeah, and so that can help to still lower the inflammation without having to rely on the steroid. And so if you're responding well to that one, they can kind of help to balance out.
Okay. He did say that my OCT scan looks better than all of his patients he saw earlier. So I was very happy to see that.
Yeah, that's great.
So. Sorry.
So to the eye pressures, it's, extended amount of times that our eye pressures are high that we start to get the damage to our optic nerve. 30 is kind of a magic number that we want you to be below. And so that's usually when we start to intervene with eye drops to lower it so they don't get damage to the nerve. But when you're having a higher pressure for a short amount of time, it's a little less concerning than, okay, your eye pressure's been 30 for a year or 40 or whatever it might be. Then we start to worry that you're actually going to have more, actual damage to your optic nerve versus a short time that your eye pressure is high. It's less likely to affect your optic nerve.
Okay. One thing I did want to tell the group, if you got, and this is just me, so, and maybe it wouldn't happen to other people, but I did notice I had to increase my insulin. And I think it is also from the steroid too. And they had told me that, it's such a, minute amount, but my body has a tendency to be very responsive to medication anyway. So that was just something that I needed to. I didn't change my eating routine. I didn't change. Well, I didn't exercise as much as I normally do,
Yep.
post surgery, but
Yep.
I did. I watched that, and it did increase my blood sugar. So if anybody else it's something that you might want to think about, even though most of the doctors say it won't do anything.
Yeah. So even though it's an eye drop and you're, putting on topically, the drainage in your eye, the lacrimal drainage connects, to the rest of your system. So even though seems like it's just going to be on your eye, it does get absorbed systemically. And so people who respond, say, to systemic or oral steroids, you still can have a little bit of that from even just the eye drops.
And I did not a huge amount, but I noticed, my average, which went up about 20 points. So
yeah. Good to keep a very close eye with the finger pricks and the CGM when you're just post surgery like that. It's hard to say. Each patient can react just a little bit different, even though they have the same diagnoses.
Yeah.
As we know, it's not a cookie cutter.
Science, no. And I have a CGM, so I'm very grateful for that.
Yeah, good to have a lot of feedback as to that.
Yeah, thank you.
Just curious, did you do your surgery around Minneapolis area?
Yeah, St. Paul Eye Clinic.
Okay, very good.
Yep.
Yeah.
So, yeah, but it's just scary. And I had 2 years with eye injections and stuff, and it's like, oh my God, should I be doing this? But there is a big difference in my vision, and I'm very, very happy. I can now see 20/25. Before my vision was 20/80 in that eye. I couldn't see very well at all, but I haven't had the other one done yet. He still wants to get the pressure down, and so I'm going back again next week. So hopefully he'll give me the all is clear to get the other one done.
Yep, and good that they're keeping a close watch on you versus just letting you go for a little while. They're definitely very on top of what's going on. So that sounds good.
Yeah, they
are. Could I ask? Are you getting it done by Dr. Horkey?
No,
Okay.
St. Paul Eye Clinic.
Yeah, she's based out of the Maplewood office.
No, Dr. Stanek is my doctor, and did the surgery. So I really like him. Out of 808 reviews, he got a 5. So
that's very impressive.
Yeah. Good. So okay.
I have a question.
Yeah.
I'm not sure I'm coming in. My name is Rick, and in fact, today's my 71st birthday, so I'm 71. But I didn't get diabetes until I was 61. So I've only had it 10 years, but I've had really poor eyesight since I was like 8. I've had glasses or contact my whole life. So I'm just kind of wondering, is this an area I should be more concerned about? It seems like I kind of feel lucky that I only have 10 years of diabetes working at me.
Yeah.
But I don't know. And now that I think about it with eyeglasses, I wonder if this is something I go every year for my checks, and everything has been fine so far, but I'm thinking this might be the one that hits me faster than the others.
And you haven't had any cataracts thus far?
Nope.
Yeah. So, everyone gets cataracts. It's not a matter of if, it's a matter of when.
Right. Yeah.
And so just, having the diabetic factor, it can just expedite things a little bit, not necessarily for everyone.
Okay.
Certain conditions like diabetes can make us get them at a younger age. And kind of the type of cataract can be more focal. And so it can affect us more quickly, more quickly have a reduction in our vision versus when the whole lens just gets kind of cloudy and foggy with age and sun exposure over time. You can have just kind of an overall haze of your vision, but sometimes when you get a more focal part of your lens that's affected, it can, if it's in the center part, it can make the vision go down quicker. But if, so being in the 70s, you likely to get cataracts sooner than later.
Right.
Like I said, the early 70s is kind of like the average age for cataract surgery, which means that they're ripe enough to take out. So typically,
my doctor said I've had the beginnings of it, but not enough to worry about yet.
Yeah.
And then, but I'm kind of thinking more about retinopathy.
Oh,
So I should be kind of more protected from that with less years of the high sugar.
yeah.
So, and my A1Cs are good, and my time in range is good too.
Yep.
So.
Yeah. So controlling those factors is going to be one of the biggest ways to reduce your chances of getting retinopathy.
Okay.
And even someone who has the same amount of years of diabetes, same A1C, the same time in range, you know, one of us can be a little bit more susceptible to having those changes than the person next to us that's had it for the same time and has had the same sort of control. Because I know sometimes, like, say we go into our endocrinologist, and it's always like, sometimes feel pressure about your A1C and, you know, making sure that you're maybe a little bit nervous about the visit or something. And I feel like some people get that way about getting the eyes checked. But it's sometimes not what you're, you know, doing or not doing that's making that change in the back of your eye. Like I said, you know, same people or different people could have the same things going on with how long they've been diabetic and the control. And one person just might be a little bit more susceptible to having those changes.
So the fact that I've only had it 10 years, I'm almost more like a person who hasn't had it if I haven't had any problems.
You know, I've had, you know, I've been diabetic for 23 years. So your chance of retinopathy is less than mine.
Yeah. Okay.
Yep. Definitely.
Thank you. Thanks for that.
Yep. And then, yeah, I was just touching on the overall refractive changes you can get with diabetic. So, you know, we can be born nearsighted, farsighted, where either when light comes into our eye, it's not focusing on the right spot in our retina to see clearly. So we need glasses for far away, or we need glasses for up close. But different parts of the eye, if we have changes to them, like the lens in our eye versus the retina, we can get different types of shifts in our vision. So say someone who has always had nearsighted correction or glasses for far away, and then they get fluid buildup in the back of their eye in the macular area that we use for our central vision, like our 20/20 vision. That makes your eye seem shorter, so it makes your prescription less. So say, you know, you're like a -6, you need glasses for really far away, then all of a sudden your prescription gets better. It could actually be because you have some fluid in the back of the eye. So when we see changes to your glasses or contacts that is significant in a short amount of time, we definitely want to have your eyes dilated and check the different parts of the eye to see if there's a reason that could be causing that, versus it being, you know, just kind of age progression, natural course that your eyes might be taking. Sometimes I'll see patients whose A1C was, you know, 6 for many years, and then say they have to be on oral steroids, or they have a significant health change in another part of their system, and their blood sugars go out of control, and say they're up to like a 10 for a couple of months. They'll come in saying that their vision's changed, and they'll have a significant change to their prescription that I'm reading. But a lot of times they don't prescribe it right away, because if our blood sugar is elevated for about 3 months, it can have a change to our vision. So we want stability of your A1C when we're changing your glasses. Otherwise, you're kind of can be wasting money doing a change to your glasses, but then your A1C gets back under control again, and it could shift back to right where it was. So we always want to investigate further when we're having a shift to your prescription. I always also want to check on macular degeneration. You can have a little bit of an increased risk with that, but it's also just another common eye disease that I want to touch on. So the macular area, like I said, is where you get your 20/20 or your central vision, where we use our glasses and contacts area for. You can get little deposits in the back of your eye that can cause you to lose your central vision. So say glaucoma is a disease where you lose your peripheral vision. Macular degeneration is a disease where you can lose your central vision. But the biggest risk factors are age and smoking and family history. When we start to see changes to those areas in your eyes, we always let you know. We might monitor you more closely and recommend some things like eye vitamins that can be helpful for that macular area, like lutein and zeaxanthin. You might have heard of like a eye vitamin like Preservision or Ocuvite, things like that, have those vitamins in there along with a couple other that can be very beneficial for that macular area if you're having changes. But yeah, and then quitting smoking or not taking up the habit of smoking is a major risk. And then wearing sunglasses when you're outside can really protect that central vision area, whether or not you have changes already to that area in your eye. So good for everyone to wear sunglasses when we're outside. So yeah, just going back over some of the ways we can reduce the risk of having changes in our eyes from diabetes is our A1C being controlled over time, and our time in range. So we're not having those big peaks and valleys, even if our A1C is looking good. But our overall health is the #1 way to reduce ocular complications. So controlling your blood pressure, your iron levels, your cholesterol, all those things can have kind of a compiling effect and exacerbate each other. And you can have multiple disease processes in our eyes too, not just diabetic changes, but also blood pressure changes if they're both being out of control. And then working with your endocrinologist or primary care with your routine visits if you are having troubles in any of these categories to make sure that the medications are in check and going over your numbers with them. And then your diabetic eye exam, even if you aren't having changes, just to make sure that we get every area checked out, because not all of them you might not have symptoms for. So always good to go in, even if you're not having any troubles, once a year. And then I was just going to touch quick on vision therapy, also not super diabetic related, but kind of has turned into one of the areas that I've focused on. So when I was kind of shadowing through the process of figuring out the area of optometry that I wanted to focus on, I always found it interesting, you know, how systemic diseases could affect our eyesight. But then the more I got into it, I thought it was really interesting that even if you see 20/20 in one eye or both eyes, it doesn't necessarily mean that your eyes are functioning well together. So I say a lot of patients that come in and they're complaining about double vision, like seeing 2 of something. They close an eye to read, or they have trouble following along when they read, and they have to use their finger. They get headaches every day. They have poor hand-eye coordination. They're like, oh, I've just never been good at baseball. But a lot of times there's a reason, and that their eyes aren't working together properly, that they're not having good depth perception, things like that, that can impact how we take information in and how we interpret that information. So a lot of times it's just a matter of family history. Like if you have like an eye turn or a lazy eye, a lot of people will call it. If you've had an injury, like a concussion, so traumatic brain injuries, car accidents, acquired brain injury, like a surgery. And then we train the eyes to work together again and to take in information more efficiently. So it's kind of like some people say like physical therapy or occupational therapy for the eyes. We'll train one eye, the other eye, and then both eyes together to be more efficient. And then a lot of people have improved hand-eye coordination, depth perception. Kids have gone from, I don't like to read, it's not for me, to they're bookworm, interest in different areas of sports, and things like that. So just another area that I wanted to touch on to get the word out about. So I want any other questions from anyone?
I have a question. My name is Carol Logan, and I got type 1 diabetes when I was 58. I also was told I couldn't have type 1 because I was too old. So I was misdiagnosed for about a year, but it's definitely type 1. And so it's been 21 years now. And so I'm 79. But I belong to this group. I'm sure you've probably heard about Dr. Richard Bernstein, Dr. Bernstein's approach. And he believes in extremely low carbohydrate diet, and a normal A1C is 4 for a non-diabetic. So in this group called Type 1 Grit, which is people who follow his approach, somebody mentioned that actually there seems to be a correlation between having an extremely low normal A1C, like around a 4, can actually predispose people to eye problems. Do you know anything about that?
Yeah, so there can be kind of 2 ends of the spectrum where, you know, being hyperglycemic can cause a lot of these eye complications, but also if we're hypoglycemic or too low, it can cause different stress factors in our body too, that can make our blood vessels more susceptible to having leakage. And so sometimes too tight of control can cause changes to our eyes too. It's a little less common, but some of, a little bit more of the extreme A1Cs, like a 4, you definitely could also see eye changes.
Well, I don't think they necessarily mean that you have hypoglycemia. You don't necessarily have to have hypoglycemia on a low carb diet.
Right.
You could still be in very good control and not have hypoglycemia. But the point somebody made was that even with that, for some reason, some illogical reason, it could still cause problems with your vision without having hypoglycemia.
I think it's related to some of the stress factors in the eyes. I don't know the exact mechanism, but and it's definitely not as common, but I have encountered that as well.
Okay. Thank you. This has been very interesting. Thanks.
Thank you.
I have a question about dry eyes.
Yeah.
If you feel like you're starting to have dry eyes, can you just start over-the-counter eye drops, like the re-wetting drops and stuff? Is that the best start?
You definitely can. So there's a lot of different categories of the dry, like your tears evaporating, the glands not functioning, having inflammation on the front surface of your eye. And so sometimes it's a good place to start, but maybe not be your best route. If you need more inflammatory control, things like that. I always recommend those starting with some lubrication drops that have a little bit of that oil component, especially if you're female, because meibomian gland dysfunction and that lipid layer of the eye can be more affected in females. And so I like lubrication drops that have, they'll say like omega or like oil component to them. So Sustain, Complete, or Sustain Balance are really good drops to start with. So they're like Sustain, Refresh, Blink, they're all good like over the counter ones, but they're all just made up of a little different composition. And some of the re-wetting drops that are more for like contacts and things like that are a little thinner in composition, so they don't stay on your eye as long, but they don't gunk up your contacts either. So if you're not wearing contacts, I'd recommend one of those thicker eye drops that have an oil component to them.
Okay.
Yeah.
And then my son did vision therapy with Trent Cole for 4 years at least. So.
Oh, wow. Yeah. It's a small world. There's only a couple of clinics in the Twin Cities area that does it. So.
Yeah. And that was quite a while ago. So when he first got started. Yeah.
Made a difference though?
It did. He has lots of different, he has special needs, so lots of different things.
Oh,
but yeah. But I tell you, it's like PT, it was torturous to do those exercises. Oh man, he hated going into therapy.
Yeah, so a lot of times we'll see him once a week in the office and work with a vision therapist, and then send you home with eye exercises to do at home. We tell them just like sports or school, got to put the work in at home to see those improvements, but it can be tough when you're in it for a long time.
Yeah, yep.
I have a quick question. Is lutein kind of a general recommended thing or not necessarily?
Yeah, lutein zeaxanthin can be good for everyone. It's just especially good for people who are having the beginning signs of macular changes. Yeah, especially as the years go on, we can be more susceptible to that. So it is a good overall lutein zeaxanthin like eye vitamin for people. It comes in a formula that I like though too, if you're not taking a multivitamin, where it has vitamin A, C, and E in there as well. And so it can be a good like mini multivitamin if you're not taking anything else right now. It's called Red's 2 formula.
How do you spell that?
AREDS 2. And different brands will make it, so like Ocuvite or Preservision, Retain has one as well, I think, just called like Macular Health.
It's just plain lutein. I can't remember if you said that's also an option.
Yeah, so lutein in combination with the zeaxanthin. Let me pull that back up here.
Sorry, I missed a little bit. It was probably
okay.
went over that.
Yeah, nope. Lutein, zeaxanthin for 2 of the eye vitamins there that can help the macular area.
Is that typically, like, I've had diabetes for 34 years, I guess, and type 1. And I believe, no, neither. Oh, I think my dad, I mean, he's in his 80s, but he has beginning of macular degeneration, but I don't know that he had, I think they started him on lutein. So then I was thinking, well, maybe I should be taking it early. So, you know, with my diabetes kind of thing, but I don't know if that's the right way to think about it.
Yeah, there's been a little bit of mixed reviews if it's necessary or not necessary if you don't already have the signs in your macula. But with the family history, I always recommend it.
Okay, that makes sense. Thank you.
Yeah, yep.
So would that be a good vitamin for DME too?
It can be with the, because that's the area that you can, the macular areas where you get that. But I wouldn't, you know, all the other treatments that they're doing with the laser, the eye injections are where you're going to see the most benefit.
Okay. Thank you.
Yeah.
Now, Kelsey, do you or would emergency room providers end up seeing something like retinal detachment with a case of trauma or other things?
Yeah. So we see a lot of emergencies at our clinic from anything like a foreign body, like I got metal in my eye, you know, I got debris from the wind in my eye, to I have new flashes and floaters. You know, I need to see if you're having a retinal detachment, I'll send you to the retinal surgeons. But when we're having some of the symptoms of retinal detachment are like when you have new floaters in your vision, like black spots or flashes of light, kind of like a camera going off in your eye, or like shimmers of light off to the side. Those are symptoms of macular degeneration, but they could also just be changes to like the jelly in your eye, the vitreous that kind of holds the eye shape. As we age, that jelly in our eye becomes more liquefied, and it kind of shrinks and pulls away from the retina, and it can cause just floaters in your vision. That's how everyone kind of starts to get floaters in their eyes. But if you're having those sudden new floaters, it could have caused like a break or a tear in your retina, which can lead to a retinal detachment. But we see all those types of emergencies and see what's going on if you need to be seen by a surgeon, or sometimes we'll watch you in like 4 weeks to see as the jelly kind of goes through an active process to make sure the retina stays healthy during that process.
Okay, good to know. Thanks for that, because I'm like, I wouldn't know what to do if that happened.
Yeah.
You go to the ER and then all of a sudden they tell you to go some other place and you waited for an hour or two or something.
Yeah, unfortunately, a lot of urgent cares and ERs don't have the slit lamp. So when you put your head in and we look with lights and lenses, so if they don't have that, then they're just going to, you know, refer you to another clinic. So sometimes we'll get from like the local, like Northfield Clinic or like Apple Valley Clinic. We'll get people who went to urgent care, they couldn't see them, and then for what they need to be seen for, and then we'll see them as well. So it can be a little out of your way to go to urgent care or the ER if you're having those changes. The only thing that we really send right to the ER is if you're having sudden loss of vision where everything kind of goes black, where that could be more like a mini stroke in your eye. And then you'll have to be seen by the ER anyways. But for the most part, all those other symptoms, we can see you first, or you can call into our clinic and we'll kind of triage you and let you know to come in or to go somewhere else.
Cool.
And not a lot of optometry, or not all optometry offices, I should say, do see eye emergencies. So you can always call and they'll try to get you in touch with who would see you.
I have another question, Kelsey. So when I had open heart surgery afterwards, they put you on an aspirin for life, basically.
Yep.
And when you get diabetes, they have certain things they have you do for life. So is there anything like that with because you have diabetes with your eyes I'm just looking at this lutein, is that something that kind of is not prescribed, but just recommended that you just start on it?
Not necessarily.
Okay.
With the
So is there anything for eyes that you just Or is that one I can finally not have to worry about?
A
Just
little
put
bit
my
of one you
contacts or
don't-
glasses on.
Yeah, a little bit of one you don't really have to worry about. I would say the biggest thing is sunglasses when you're outside, because
Yeah.
it can affect like the white part of your eye, causing sunspots. It can cause the cataracts in the lens in your eye. It can cause macular degeneration, macular disease. So I'd say more so, sunglasses would be a number one recommendation for anyone who doesn't have anything else wrong with them.
Okay.
And so it's not that you need to take lutein zeaxanthin just because we're diabetic. It just happens to be if you're having macular changes or at risk for macular degeneration, that then I would recommend it for you. Yeah.
Okay.
It's not one that you need to add to your regimen right now, unless, like when you go in that they recommend it.
Okay, thanks.
Yeah.
Now, Kelsey, statins do stuff for your other blood vessels. Do they ever do anything for eye blood vessels?
They can. So certain medications, if you're taking systemically, it can help your eyes. Like say like a beta blocker can help you if you're having high eye pressure. The statins can help, if you need to be on a statin, there's a reason for that, and it can help with your blood vessel health, so you don't get you can see little plaques form in your blood vessels. It can cause an occlusion of that blood vessel where you get hemorrhaging or lack of blood flow to a certain part of your eye. So indirectly, yes, it helps all the blood vessels everywhere.
Gotcha.
It's just interesting that the eyes are the only place you can see blood vessels without cutting you open. It's the only place you can see live blood vessels. So it's a good insight if you do have changes that we can tell systemically what might be going on, like a anemia blood hemorrhage versus a diabetic blood hemorrhage are going to look different. And so for everyone, I recommend having an eye exam, on an annual or biannual basis, even if you're young and healthy, because little things can pop up like that can tell us about your systemic health.
Gotcha. Thank you. I think it's kind of a dumb question too, because I don't think LDL cholesterol really transports in your eye as much, but maybe that's not the case. I don't know. So.
Yeah, so a lot of times when you throw a plaque, from one of your major arteries, a little piece of that can get into, your
eye,
tiny in your eye, so it can get lodged more quickly in your eye versus other, veins and arteries.
Okay.
So Kelsey, I'm curious. The doctor today was going to switch me to a different glaucoma eye drop that was a beta blocker drug. But
yeah.
he had asked me, and I didn't ask him why he decided not to do that. But he had asked me if I have any heart issues, like if I get low blood pressure or my pulse is low. And I've had that too. So so he said, okay, well, we're not going to do that now.
Yeah. So yep, there's different ways we can lower the eye pressure by reducing the amount of fluid that we produce in the eye, the aqueous humor, by getting more aqueous humor out of your eye, or changing the kind of drainage of how the meshwork of how we can drain that. But if we have, beta blockers, risk factors, like you can have the low blood pressure already, then, certain people are better fit for certain medications based on the different mechanisms that they can go through. So sometimes staying in the same maybe glaucoma drop or eye pressure lowering drop that you're on, but just changing the frequency can help too. And different times of days based on the mechanism of which eye drop you're on can be different times of day can be more effective too.
Okay. So it wouldn't put a person who has a heart problem at risk of having a heart attack or something.
Yeah, so we just be careful with certain things like that, but there's so many different glaucoma drops and eye lowering pressure drops to choose from that if we can stay away from that one for you, we will.
Okay, thank you.
Yeah.
You talked about the jelly in the back of the eye, the vitreous fluid drying up as you get older. So is there something that can be done for that?
So the vitreous in the back of your eye that kind of helps hold its shape, that changing over time, we don't have a lot of control over when it kind of changes composition and shrinks. it's kind of a matter of if not, or when not if for that as well as the cataracts. I would say like high velocity or high impact sports could have a little bit more of an effect on it, but in general, it's kind of like the natural aging process. Some people get a symptomatic experience when it happens, and some people it happens and they don't get any symptoms. It just kind of depends what part of the eye that the kind of floaters form or the little changes kind of consolidate to. Some people it's in that very central vision, it's a really annoying floater, and other people they have a floater, but it's below their central vision, so they don't really notice it.
And so there's nothing you can do about it, but as diabetics, does it tend to happen quicker like cataracts?
No, not a big association with that one.
Okay.
Yeah.
Well, for the eye exam, so I go in for the yearly exam, and I know they usually, well, we're at my clinic, they usually do a refraction as well, so to check my vision. And I have run into insurance not covering, but being diabetic, is it important to still have the refraction, or does that part not even matter? And it's really the dilation part that.
Yeah, the dilation part is the most important, but if you have a big shift to your vision, like your vision's not 20/20 when you come in, they should take a vision on you no matter if you're having a refraction or not. So if your vision has changed from the previous visit, I would say the refraction can be important to give us more information as to what could be going on with the eye. But the dilation is the most important part. So if that refraction is not covered, it's fine to do like every other year, as long as you feel like your vision is stable and you're still seeing well with your glasses, or if you don't need glasses, you're still seeing the same.
Okay.
A lot of times too, so diabetes is the only medical condition that an annual eye exam is usually covered by your medical insurance. It's the only medical bill that even if you don't have diabetic complications, that we can still bill that you have a healthy diabetic eye, and that your medical insurance should pick it up. So a lot of people don't realize that you can bill medical insurance and not your vision insurance for this part.
Yes, that's helpful. And it was still with the previous insurance where the refraction, they would cover for the exam, but not the refraction.
Yep.
Unless it was 2 years. And I was kind of like, wait a minute, it's just part of my exam. Because at my clinic, they automatically do it. They didn't even ask if I wanted it. And, and then I get billed whatever, a couple hundred or whatever it was later. I'm like, what?
Yeah. Yeah. So the refraction should be a smaller portion in terms of like, you bill for like the dilated part and then the refraction. So it should be a much smaller dollar amount when it's not covered. But if you're getting a large bill back, I would, call into them and see if the whole exam was denied or if it was just a portion. Like
it was just the refraction.
Okay, good. Yeah. Yeah.
Maybe it wasn't at 200. It might somewhere between 100 and 200. I don't remember.
Okay. Yeah. So
the other was more.
For how much they charge for that part. I would say I would have expected you to say more in the ballpark of about $50, but yeah.
Oh, really? Wow.
Yeah.
Okay.
It just depends.
Maybe it's the clinic.
Yeah, it could be. It could be.
Yeah. All right. Thanks.
Yeah. Yeah, so when you guys, when you call in for an eye exam, you can always mention that you're diabetic, because then they'll know to ask you for your medical insurance versus your vision insurance. Your vision insurance you can still use for refraction, glasses, and contacts coverage, but there shouldn't be a problem getting the actual examination for the dilated portion covered by your medical insurance.